Hi.
Hello and welcome to Knock Knock Hi with the Glaucomfleckens. I am Dr. Glaucomflecken.
I'm Lady Glaucomflecken.
Will and Kristen Flannery. Thank you for joining us today. Knock Knock Hi.
Oh, you did it.
Knock Knock.
Hi.
I promised people I would do that.
Yeah, a lot of people, you made a joke about it, and they said they actually did want that.
So we recently moved to a new YouTube channel for the video version of the podcast.
Yes.
So all the Knock Knock Highs, all the Knock Knock Eyes, clips, everything.
Glock Talks.
Yeah. And the reason we did that was because we were confusing YouTube.
Mm-hmm.
And we had some advice given to us by someone at YouTube who says, hey, yeah, maybe separate them out, you know?
Yeah.
And
because it was getting hard for people to find your skits because
the
YouTube algorithm was starting to think that the podcasts were the ones that should be pushed out and the skits should be suppressed.
Right.
Because of that.
And
I think
YouTube the algorithm had a headache, everyone.
Yeah. It didn't know what to do with you. It didn't know what category to put you in and who to share you with.
Exactly. So we moved it over to our new channel at Glaucomfleckens. And that's going to be the new home for everything. And I announced this a few weeks back, and hopefully everybody's found their way over there by now. We've talked about it a little bit before. And so if you haven't yet, go over there. Subscribe.
Yes.
All right. At Glaucomfleckens.
Or youtube.com/Glaucomfleckens.
That's it. Yep. Everything. I'm still going to be making skits on my normal channel that if you're watching this and you're a fan of YouTube, you can still find all my normal stuff over there. But the podcast episodes are at the new channel. And I got a lot of good feedback so far. Like a lot of people were like, yeah, that makes sense. Let's do it.
Yeah.
Just separate the two out.
They're different things. One's short format, one's long format, one's more entertaining, one's a little more educational. So makes sense.
I have stopped trying to understand algorithms, you guys.
Yeah.
Like I feel like it's so hard to predict.
Well, they change, and no one actually knows except for the people writing them.
Yeah, and unless you're like Mr. Beast and he like studies it.
Yeah.
And to try to figure out how to best make the algorithm work for him.
I don't have time for that.
I don't either. I'm terrible when it comes to like trying to time my thing. Like my skits, I'll like post them on TikTok at like midnight.
Yeah, because that's when you're doing
Something
it.
tells me that's not the time you're supposed to post new content on social media is midnight on the West Coast, you guys.
Right. So middle of the night for the rest of America.
Worse. And that's just because that's when I finish it. Yep.
That's when you're filming and you're done.
I'm done. I'm like, okay, this is it. This is good. Let's put it out there. I don't know. This is why I need you.
I know.
And the rest of our team.
That's right.
To like make me think about like, oh, maybe you should like,
schedule that for
think about
later.
The time and how you're posting these things, not just throw things out on social media. I don't know.
When do you guys want him to post? Tell us. We can do it then.
Yeah, I don't know. I mean, we're going to get different times for everybody, right? I mean,
I guess. I don't know.
I'm guessing, though, nobody's going to say 2 a.m. on a
Only
Friday
the
morning.
Insomniacs prefer that.
Maybe some of you night shift
When do you
folks.
look at social media?
Not at 2 a.m.
It seems like first thing when you wake up and then like as you're going to sleep.
Well, no, I'd say
when you get in bed, but before you're ready to
a little
actually
bit
go to sleep
because do as I say, don't do it. What is it?
Do as I say, not as I do.
Yeah, that's it. Do as I say, not as I do. We should not be looking at our phone right before bed.
I know it's poor sleep hygiene, but I think a lot of people do it.
I know I'm guilty of it.
I think the vast majority of people do that.
So now you've outed me as a terrible sleep hygiene person.
Was that a value that was important to you?
I've staked my reputation on it, Kristen. Okay. Anyway, the point is, check out the new YouTube channel. That's where all these are going. It's been a process trying to get that done, but anyway.
Yeah, hopefully by now, as we're recording this today, we are actively in process of transferring. So hopefully by the time people are hearing this, everything's going smoothly.
And by the way, you could check out our website too for like all the things we got going on. We got like a live tour coming up. Like you could buy tickets to that now. This is the time where we shamelessly promote all of our things.
Starting next month.
All of our things. But let's talk about our guest today. We have Dr. Sayed Tabatabai. He's a
Say
friend.
what?
Tabatabai. Tabatabai.
Yeah,
Tabatabai.
Dr.
Sayed.
Sid.
Dr. Sayed Tabatabai.
Sid.
A friend of the pod.
He is a friend of the pod.
Friend of the Glaucomfleckens.
Yes.
He was on our live show. He decided to have him come back for a little bit longer conversation. Clinical nephrologist and published author. He has his current book is These Vital Signs, which is a series of stories and tweets and things that he's talked about on social media. He's a very, very fantastic writer. So he came to talk about, he told us some stories
Yes.
about his time as a nephrologist and an author and all these things. So
he is kind of a rare combination of very wise and funny.
he's got my favorite type of sense of humor, just bone dry.
Yes.
Love it.
Right.
I love
it takes you off guard because it is so just
I
like
love a
it
good
sounds so serious, and then it takes you a second to realize it's a joke.
dry
Very
sense of
good.
humor. Fantastic. All right, let's get to it. Here is Dr. T. Today's episode is brought to you by the Nuanced Dragon Ambient Experience, or DAX for short. To learn more about how the DAX Copilot can help reduce burnout and restore the joy of practicing medicine, stick around after the episode or visit nuance.com/discoverdax. That's nuance.com/discoverdax. All right, we are here with the one and only Dr. Sayed Tabatabai. Dr. T, thank you again for joining us.
How do you do on your name?
That was amazing. That was
Okay,
really
good.
good. I'm impressed.
I've been crushing the pronunciations lately. Sometimes I don't know what it is. I have trouble with my words.
Yeah.
So Dr. T, Kristen told me recently that I am a slow talker.
Yeah. I had to break that knowledge to him. He
And
didn't
that-
realize that.
And that it might be difficult for our audience to listen to both of us.
Because I'm a fast talker and he's a slow talker. So if you want to put it on like 1.5 speed or something, like I'm going to be a chipmunk, but he'll finally speak at a normal pace.
I guess my point is to you, don't worry about how fast or slow you talk because we got all the speeds covered over here.
I love it. I love it. I think it's a relaxing speed. It's
Ugh.
See?
It's frustrating for me. It's like, spit it out.
So here's what it is though. Because actually this is great because you are practicing, you're a nephrologist in San Antonio. So I grew up in Texas.
Mhm.
I just everybody just talks a little slower
Mhm.
in the South. They just-
However, I also grew up in Texas.
yeah, that's true. I mean, it's not across the board. Okay, it's not. But I do remember like moving to New Hampshire for med school,
Mhm.
and all of a sudden, everybody just spoke like a mile a minute. So
Yeah.
there's regional differences for sure.
Also, when I was in grad school in New Hampshire at the same place, uh, people would like explicitly judge anyone who talked slow. Like they thought they were stupid. That was the assumption.
yeah.
The first assumption is
That's
that
no good.
person's not very smart because they're a slow talker.
Where did you grow up, Dr. T?
So I was in upstate New York and quite
Oh.
a few
Fast
fast
talkers.
talkers. Fast
Yes.
talkers.
Okay,
And
so you
then
went the
my
opposite direction. Yeah.
My first job was in Salisbury, Maryland, which is a rural farming Eastern Shore, community. And I was used to the New York style. So it was the most frustrating few months of
Thank
clinic
you.
when I
See?
started, listening and trying not to interrupt the patients, trying to do
Yeah.
all the good things, and by the same token, I'm like, sir, I'm sorry, you're gonna have to speak faster. I can't do this.
You can't speed up
Yeah, there's no
in
1.5
life.
speed for real life. So
So you were just telling me before we started recording what your Monday is typically like. Tell us, what do you do? How much time do you spend in the dialysis unit on Mondays?
So it's time management, I think, is a big part of my day. I mean, for everybody, I guess, but in nephrology you have to be in different places. So I have to round at dialysis units, I have to go to the hospital, and I have to go to clinic. And so clinic being the office, the
That's a
outpatient
lot.
office. So yeah, so every day it's just kind of in the morning looking at my censuses, figuring out what the best way to squeeze in all those things. You sort of get into a routine, so that's good. But Mondays are especially chaotic because I wasn't on call on the weekend, so I don't know quite what's going on
Yeah.
everywhere. So
You you occasionally have trainees with you, like
Yes.
sometimes they rotate through.
Yep.
Does that how do you feel about those days? Are they does it
to speed things up or slow things down, make it more complicated.
It
or just
definitely
more
s
fun?
it definitely slows things down, because I'm one of those attendings where, I always feel bad for the trainees. I always wanna be like, "Are you getting is this high yield? Is this high yield enough?" I feel like you're just watching me do stuff that's not high yield, like, I've
As
gotta
you
stop
point
and
as you point to a whiteboard full of nephrons and
Yeah, exactly.
calculations, "Is this high yield for you all?"
Yeah, exactly. So it does slow me down, but by the same token, I think it's more fun too in a
Mhm.
way. You know, because and I get a lot of good questions and they give me good feedback and it's fun.
What's the, can you tell when you're working with a trainee when you lose them, like, in
Oh yeah.
rounds? Like, can
Oh
you,
yeah.
like, what is it about their face, their body language, like, that you catch on to?
So the eyes go kind of glassy, the jaw gets kind of slack, the body posture starts to slouch, the slow recline back, and like the head, you start to lose neck muscle tone and just general flaccidity.
Like,
Yeah.
they're trying to slowly get away from
Yeah.
whatever it is you're trying to teach them. What are
Yeah.
the Tell us, what are the topics that probably, that or what are the things that you talk about that results in that kind of reaction most often?
Most often it's acid-based stuff or sodium stuff. Those are just everyone's, there's
Sure.
just such a there's I think there's now such a mythology built up around them that when the topic comes up, it's sort of larger than life. Even though I'm not just saying this as a nephrologist, it's not that bad, but I think it's like math and it's like, people just sort of glaze over. It's just numbers and formulas and people are like, "Ugh, that's
I
that's rough."
I can't believe, is there, like, a content creator that maybe, like, keeps making fun of that and bringing it up all the time? I don't know.
Not a very good
Is
one.
that no? I don't think, yeah.
Dude, I was so happy though, I gotta say, you used my joke. You said you were gonna use it, and you used it on
Which
the
one was it?
nephrology lab, the dehydration versus volume depletion one.
Yes.
Yeah.
I was so overjoyed. I think I texted my parents. I said "I shared this joke with him," and
Let's
they were like,
tell the audience. Set that up. What did
"Oh my goodness." So, one of the things nephrologists are notorious about is our focus on terminology. Like, you've gotta use the
Yes.
right terminology. And like a classic example of that where people will say dehydration and nephrologists will fixate on that and say, well, actually, dehydration refers to water. It's not really volume. And if you're talking about volume, it's volume depletion. And you captured that beautifully in your skit. I did a tweet about that, responding to something you said about nephrology. That if someone says dehydration, it's like the bat signal, and all these nephrologists will show up everywhere and just sort of lean in to see what the conversation's about. And you had that, you had all these other guys sipping on their Morton's canisters. It
Yes.
was so great. I
Well,
loved it.
I loved that response you gave me. I was like, "This is perfect." I had that tweet up on my computer as I was writing out the script. It was like, "I gotta make sure I get this right," because obviously, and I had several uh, tabs open of different sources because I got to do a lot of research for stuff. I don't know anything about nephrology. Are you kidding me? So that was really helpful, and was a perfect just image of, oh yeah, it makes sense. There should be like a salt mafia
Mhm.
of of all these nephrologists that descend on you whenever you say the wrong thing, because we're all so caught up in our own
Yeah.
terminology. It is not just nephrology. Maybe you're like top 5 of most uh most particular when it comes to terminology, but I feel like everybody's got a little bit of that. So
Mhm.
I don't know. I was thinking about what it is for ophthalmology that's like grinds our gears as far as
Well,
the
Visine, obviously.
well, yeah, but like in terms of like what, oh, I know what it is. I know what it is. It's when people put in the chart perla.
Ugh.
Perla. So Pearl. Okay. Let me backtrack because Kristen's looking at me like, "What the are you talking about?" Um, so it's an acronym. We love our acronyms in ophthalmology. I like just all over the place. We'll just
Well, it's 'cause
acronym
all your words are
the
too
hell out
long.
of the thing. Well, that's part of it. Yes. Perla is when you're describing the pupil exam. So you
Okay.
say pupils are equal, round, and reactive to light.
Okay,
So
2 R's.
perla, yeah, two R's, Perrl.
Perla.
Pearl.
I like her version.
That's pretty good. So, but the classic teaching would be that you add an A to the end of it. Pupils are equal, round, and reactive to light and accommodation.
Reactive to accommodation?
Yeah, because whenever you accommodate, let's say
I'm
you're
sorry I asked.
yeah, well,
Just move
man,
along.
thank you so much for asking. Dr. T is like, what the hell am I even doing here? All right. So you're going to learn about accommodation, Dr. T. Here we go. You probably already know it, but you look in the distance and then you move your focus to like up close,
Uh-huh.
your pupil constricts.
Yes.
So that's,
I was making more of a grammatical question. Can you be reactive to accommodation? That seems like it doesn't make sense.
your pupil is reactive
To
to
accommodation?
accommodation.
It seems like it's reacting by
Oh,
accommodating.
God. Okay. Now this is even worse than a nephrologist here. It's like a linguist.
I would have been a good internal medicine doctor, is all I'm saying. Maybe
I'm not
rheumatology.
sure about that, but rheumatology I could see. So anyway, the equivalent for us with like volume depletion, dehydration is when people put perla, they put the A on the end, but they never check. Nobody ever checks that the pupils react whenever the eye accommodates.
Mm.
So it's like that's like the one thing. It's like, oh really? Oh yeah, just tell me how did you check accommodation, sir? I'd like that kind of thing. So
Well,
I
now
think
that we've lost everyone.
I like
those
your
of you who are still
version.
listening, we're going to go into more semantics about more terminology.
I like how you made per blah a thing because round by accommodation or whatever.
Perbla. That's good. All right. So we've established that we're all very neurotic here. That's good.
We have.
Dr. T, you shared with us some wonderful stories. And one thing I just love is this. I would think that there aren't a lot of Syed Tabatabais out there. Like you get like they can't. It seems like a fairly unique name.
Yeah.
Wouldn't you
Does it
say?
have a meaning?
It's a very unique name, and it doesn't really, it doesn't really have a specific meaning. I think the
Mhm.
Tabatabai part is just a reference to it's like a Iranian last name, a Persian last name, so some ancestry. My family's mostly from Pakistan, so some ancestry somewhere along the line is where that came from. But you're right; it's not common at all.
So, it was. I'm sure it was very surprising to you to find out that there's another Sayed Tabatabai out
This was
there.
such a funny thing because the first time you get your license and you go to like the medical board thing and you Google yourself and your license is active and you're like,
Uh
yes,
huh.
this is so cool. Or maybe only I did that, but
I don't think I ever did that.
no, I think I might have been the only one. But when I put in Tabatabai, a second name popped up, and I'm like, who's this Tabatabai? And then I was like, okay, whatever. And then I didn't pay attention. And then I moved to another state for my job. So I was in upstate New York. I moved to Maryland. And in Maryland, it's the same guy. It's the same Tabatabai, the same name. And I'm like, okay, he's licensed here too. All right. And then I moved down to Texas. And I'm like, no way. I get the license. There's one other Tabatabai in the state. It's the same dude. And he's in my city. And I'm like, who is this guy? I've got to, but then I sort of put out of my mind. But in the back of my mind, I'm like, somewhere in San Antonio is this other Tabatabai who's haunted me my whole
And he
medical
must be
career.
destroyed. And he must be
Exactly.
destroyed.
And then one day I get in this elevator at this local hospital I go to, and there's another guy and an older gentleman, and he's just looking at my name tag. I'm like, what? Doesn't say anything. And then I look at his name tag, and there's total silence for a moment. And then he just says, it was so perfect. He just says really quietly, he's got a bushy mustache. He's like, it's you. And I looked at him and I was like, what do we draw swords? We're in an elevator. It's like a closed, only one of
Wow.
us is getting off this elevator. That's what I felt like.
So he knew as well.
Yeah. Yeah. And he told me afterwards that he would get like wrong orders all the time that
Oh,
nurses
yeah.
would verbally put
That's
in
right.
under his name.
It's like, who's ordering all these urine electrolytes? What on earth is going on here?
That was really funny.
What
Oh,
kind of doctor is he?
He's an anesthesiologist. So
Ah, okay. All right. That's great. Are you friends now? Or I probably just, acquaintances.
I had to kill him.
Would you?
No,
Obviously. He
sorry,
didn't
sorry.
get off that elevator.
You
He
never
did
got.
not get off that. No,
Yeah.
we're friends. Well, I guess we're acquaintances. We cross
You would
You've
nod at
made
each other in the
peace.
hallway.
Yeah,
Yeah.
You
yeah,
would say hello,
yeah. We just sort
and
of look
I'm
at each
sure.
other and we're like,
But
"Hello,
so
Tabatabai."
he was also moving, he was following you, moving
Yeah,
to
I
all
don't
the
know who
same
was following
places?
who. I think
Yeah.
we just our paths ended up crossing in multiple places. We both started in
That's
the north
bizarre.
and ended up in Texas.
Yeah.
Who's got the better facial hair?
I
I mean,
got to give
sounds
it
like
to
the other
him.
guy.
I got
Yeah.
to give it to
Yeah.
him. He
Okay.
just had it was majestic.
Okay, I got a one another. You were great with these stories. How many times? Let me actually preface it with this question: how many times would you say you have responded to a code blue in the hospital?
As an attending, not very often because they're ICU teams and respiratory therapy. But when I was a resident, that was like one of the exciting things, right? That was like you would
There's
you would
action,
run to the code, holding your white coat to make sure stuff didn't fly out of your pockets.
but in the dialysis unit, I mean, there's people are
Oh
pretty
yeah,
sick there,
yeah.
right? I
No,
mean
yeah,
that.
no. There's a fair number of codes. That's true. That's true.
Yeah.
We have a fair number of 6 people. So
Okay. And so, tell us about what's the strangest place you responded to a code blue.
this was funny. This was during residency, and there's a beep that happens before the code when they called it in my residency. It was kind of this different tone beep to like give you a heads up that it's about to be a code. It was like beep, and then say adult code 99 or whatever the thing was.
It's like so
And
everybody can like pay attention.
yeah,
Is
exactly.
that
The
okay?
beep is like the starter's mark at the when you're
Gotcha.
about to run the 100-meter dash. It's like take your mark. So I heard the beep, and everybody stops what they're doing, and it's internal medicine round. So we got another 8 hours of it anyway. So we all stop, and then it's code blue medical genetics building, and we're like, what? There's a medical genetics building? Like, what do we do? And then our senior resident is like, yeah, I know where it is. It's this way. We got to go this way. And like, we all take off running. And after about 20 minutes of running, it's pretty clear that he doesn't know where it is.
Oh no.
We all kind of split up and we're trying to find the medical genetics building because obviously a code's happening. Got to get there. And finally, me and another intern stumbled upon it, and it was like off campus and this like side. You have to go through these tunnels to get there, and it's a tower, and the elevator's not working, and it's like the 12th floor where this office is, where they call this thing. So, we finally get up there, and to cut a long story short, it was a false alarm. But both me
Good,
and
because
this
I was thinking the
intern,
person was dead by now.
yeah, we're
Like
like,
that
there's
would
no
not
way
be
they've
good.
survived this long. But we get up there, and it was just someone who is a little hypoglycemic, and they were fine. And
Okay.
but me and the intern were not, because by that point we'd run like 6 miles and climbed 12 flights of stairs. And literally,
Oh
I
my
still
God.
remember we were just lying on the ground at the medical genetics building in our full, like just lying and gasping for air. And
Uh,
it was about to be 2 more codes. But that
so
was
two thoughts on this. First, actually, this could be a good like quality improvement project. Uh, they need to. I think there are some places that they need to, in addition to telling you where the code is, they need to give explicit directions on where to find the code. Like
correct.
I feel like molecular genetics lab, they're like code blue, molecular genetics. North walk, east
Yeah, give some very well-known
east
landmark.
of the
What
cafeteria
is it
by like a
relative to
quarter
that?
mile. I don't
Yeah.
know, something like that.
By a quarter mile.
I don't know. And then also, I feel like I've heard people talk about this on social media, is that you usually don't see a lot of doctors like sprinting in the hospital. Like there's not a lot of running.
Right.
And that's like something you see a lot in like TV shows and
Yeah.
movies. And obviously when Dr. T is responding to an emergency,
Yeah.
like maybe he just wanted to get some exercise too. I don't know. Maybe that's the case. But I feel like there's not a lot of running because you don't want to be out of breath by the time you get to the code, right?
Yeah, yeah.
And so it's like
Mm.
you need to like be quick but under control.
Mm.
Because it was like I mean, could you have done effective chest compressions like maybe for like 10
I
seconds?
I
You'd be-
needed chest compressions at that point. I was not doing them.
That was great. It's been a long time since I've responded to. When was the last time you responded to a code blue?
What's a code blue?
A cardiac
Oh, that's a
That was,
cardiac. I'm not in medicine. I don't know your
so
colors.
you've been sitting there this whole time. You're like, what the hell are they
I
talking
knew I
about? The
knew a
code blue.
code is something that is specific
I'll tell
based
you.
on the color, and it means you need to hurry.
Yes. So code
So,
blue is when there's like a cardiac arrest, decompensation, heart stops,
yeah.
no breathing.
Yeah, okay. Well, I did that on May 11th, 2020. Thank you
That's
very much.
um. What are the other codes? Can you
Yeah, is there a code
how many
pink?
codes can you name?
Oh my
I'm
goodness.
more interested in why the colors were chosen because that's the kind of person
Well,
I am, but
some of them are different for different hospitals too.
oh,
Like a
well,
Yeah.
code
that's confusing.
code red is usually fire.
Fire, yeah. Code
There,
pink is usually like a missing baby or baby
yes,
alert.
someone stole a baby.
Uh-oh.
Um, there's usually there's a code for like an agitated, angry patient who might
Yeah.
be physically threatening other
Mm.
people.
Purple?
Um,
If you're
there's
really angry, you
like
go
the
purple in
active
face.
shooter code.
Yeah.
What
There's a
else?
bomb threat code.
Oh yeah,
Yeah.
yeah.
There's a fall code if someone has a fall.
There's
Um,
So, do
there's
you
hold
all
on.
know the colors when they're called, or are you like, hold on a second, and you
Yeah,
have to reference?
yeah. I mean, everybody knows code blue. There's also a ophthalmologist in the ICU code.
Hmm,
I don't know. That's a code royal blue.
I see.
oh,
Yeah,
nice.
yeah. Um, but no, we don't know. We don't know.
It just seems
We
like an
have a badge.
inefficient.
Usually they're on a badge, right? I
Yeah,
So
they're
haven't
these
worn
are
a
all
wearing a
badge
like
in a long
badge.
time.
emergency. Oh, okay. So it is somewhere that you can see it very quickly.
Yeah, you just
Okay.
turn around and look through it real quick, figure out what
Because these
code.
all sound really time
Yeah.
sensitive.
I just look at everybody else's faces and judge the level of panic. And
Yeah,
I'm like, are we good? Okay, we're good.
right. Is there a code brown? Black?
Uh,
Well, code joke code brown or real code brown?
No, real.
Because real joke code brown is when somebody poops their pants.
Well, sure.
But real code brown, I think there's probably, I don't know.
You gotta have.
Like I said, everybody's got different code
Yeah.
combinations. All right, well, we can talk about something else now.
code
Let's
teal.
code
Yeah.
teal. I don't know.
Chartreuse.
What else
Chartreuse.
could we have codes about? We could come up with all kinds of codes. I want to talk about let's talk a little bit about your decision. I love hearing origin stories. Your decision to pursue nephrology, because I feel like it takes an analytical mind. It takes
Yeah,
Hmm,
someone who likes
Math.
math.
it's interesting because all of the things you would think you would need to like nephrology, like I hated all of them. I actually went to med school originally thinking I would do a surgical specialty. All my mentors were surgeons.
Mm,
And by the time I was entering, my tail end where I had to like make choices, at that point I was like, I just don't have the passion for surgery. I'm not sure what I want to do. And I was leaning towards medicine, I like pediatrics and was kind of in that general medical student kind of lost period where I wasn't sure what the hell I wanted to do. And then I had a rotation in nephrology, which I tried desperately hard to get out of. It was kind of I tried swapping with other people. I was like, "Hey, I've got a medicine rotation. I'll swap you here." Yeah, and they're like, "What medicine rotation?" I'm like, "Well, it's just kind of internal medicine and nephrology," and it just never worked. I could never get out of it. So I was like, "Fine." I gritted my teeth. And like most things in life, I think I was lucky to have a really really good mentor and
yeah.
I had a couple of really good mentors who taught nephrology just really really well, and it was something I had done very poorly on initially in med school in this exams. And then they explained it in such a way that suddenly these concepts I'd never really understood were clicking for me. And I'll never
Mm,
forget the day, my last day on the rotation, they let me go do a consult by myself. And it was like a complicated consult with multiple things going on. And I went back and I presented it to the attending, and he was like, "Yeah, okay, sounds good." And I was like, "Holy
oh,
crap, this is amazing!" It's like I just handled all this stuff, and then I was just
that's
turned
cool.
on to it, and yeah, I loved it.
Kind of clicked to get
It
that.
clicked, yeah. It
That's
was
great.
like I could literally feel like something in my head go click in a position, and then I was a nephrologist. That was it.
That's-
Just like that.
Yeah, the nephrologist switch somewhere in there just went
Yeah.
off.
and then the surgery switch just was immediately turned off, right?
Yeah, yeah,
Nothing, like not
yeah.
anything there. Let's take a quick break. We'll come right back. Hey, Kristen.
Yeah.
We got to talk about infectious disease.
Why? What's wrong with you?
Oh, not me.
Oh,
I want
good.
to tell you about Precision.
Oh,
This is great. It's the first ever EHR integrated infectious disease AI platform.
very
Yeah,
cool.
for any specific patient, it automatically highlights better antibiotic regimens.
So helpful.
Helps with burnout. It just helps you save lives. It's
Yeah.
great. To see a demo, go to precision.com/KKH. That's precision spelled with an X instead of an E. So prxision.com/KKH. All right, we are back with Dr. T. All right, Dr. T. We mentioned we already went over what led you into nephrology as a field, which I think is a fairly unique field. I think a lot of people find it very challenging. I know I did, and I had also a couple really strong educators. I feel like maybe people who love to teach do gravitate toward that field because there's
Just a lot to explain.
yeah, so you just love explaining things to people.
What is so complicated about nephrology? Because
That's a
I
good
know
question.
that people say that, but I don't know why.
Explain.
I never think about the kidneys personally. I apologize, but
Teach us why it's so hard to teach the kidneys, Dr. T.
Teach us why it's hard to teach. I I think it's a confluence of a couple of different things. And there's a lot of memorization in med school, and I think the nephrology chunk of it has a lot of like pathways and transporters and loop mechanisms and all kinds of stuff that it gets really convoluted. And I think it's hard for people to keep that straight. And then the problems themselves, a lot of them deal with kind of mathematical principles too, and people hate math too. It's
Mhm.
like a combination of dense memorization, lots of different mechanisms, and one of the things I actually like about nephrology is one of the things that makes it difficult is that you can't have tunnel vision as a nephrologist. It's not possible to be a bad general doctor and a good nephrologist. You have to be able to, um, obviously it's cliche, but you have to see the whole patient. You have to be appreciating everything that's going on. The antibiotics they're getting for their infection, the pulmonary process that's driving you can't just focus
Mhm.
on one thing. So I think that adds some complexity to it,
Mm.
also.
Mm. Well, I there's no way I could do it.
No.
I mean, because you mentioned like it's cliche to say you have to see the whole patient. I do not have to see the whole patient.
Yeah.
If I'm seeing the whole patient,
You have to see
something has gone
almost none
wrong.
of the patient. Like you could very
Yes.
easily walk around
hmm
in a room full of your patients and
Mhm.
not recognize a single one of them because you're just looking inside of their eyeball.
I do look at their
Well,
faces.
by the time you come in, they've got the thing on their face.
I sometimes think about that. As like when I walk into most of my patient encounters, like the room's already dark.
Yep, it's dark in there.
And
They've got stuff covering their face.
their eyes are dilated, and a lot of people have poor vision or
Yeah.
moderate vision, not great vision without any correction, or certainly when they're dilated.
Right.
And so most of them probably haven't like seen my face real clearly.
Yeah, they probably just recognize you by smell.
Very good.
So you should consider that when you get ready for work every morning.
Maybe I will. One of the things that I've been learning about a little bit more recently, some conversations we've had on the podcast, is about these GLP-1 medications.
Mm.
And because it seems like everything affects the kidneys these days, or maybe that's always
Back
been the
in my
case.
day, nothing affected the kidneys.
When I was in training.
Maybe it's just everything. Everything affects the kidneys in some way or one or the other. How has how have these medications impacted your specialty, or is there any impact to them?
There's been a
Curious.
massive impact, in these medications. All the weight loss that we see impacts the diabetes that we see, impacts the blood pressure. And then there's also this study that was, I think, just last week, showing CKD improvement or benefit with just direct benefit with those medications also. So I think,
Chronic kidney disease.
Oh,
sorry,
Yeah.
in my mind,
yeah.
I was going cytokine. Let's start death.
I like that whenever you hear an acronym on this podcast, you just to yourself
I do. I try to
just
figure
come
it
up
out
with whatever that
because I
is.
figure that everyone else knows what I mean, obviously you two, and then
No
most of our
stupid
audience is
questions.
doctors,
There's
so
no stupid questions. You can always ask to clarify an acronym. Anyway, go ahead.
No, no, no.
What's happening with the CKD?
I think it's been. I think it's an exciting time in nephrology because for a long time we didn't have many options for many things. It'd be like, oh,
Mhm,
this is what you have. Watch your blood sugars. Do this lifestyle stuff, do this stuff, and we'll see you later. And we didn't really have much beyond that. I mean, not that those weren't powerful. I mean, obviously, lifestyle interventions can be
mhm.
extremely powerful, but now with the GLP ones, the SGLT2 inhibitors like Farxiga and Jardiance, and then all these other meds that are coming down the pipeline, it's an exciting time to have actually options. So when I was in training, we didn't have a lot of this stuff.
Are any of these nephrotoxic in any way?
I mean, there's always a potential for nephrotoxicity.
Of course.
Yeah, so I mean, and they can impact your kidneys. It's just one of those things on a case by case basis. But overall, their benefits as classes of drugs vastly outweigh the risks to the kidneys, or outweigh, I should say.
Do you have any kidney questions for him?
well, ibuprofen is kidneys, right? I always think of ibuprofen is bad for your
Wait,
kidneys.
ibuprofen is kidneys, right?
Tylenol is bad for your
Yeah,
liver,
that's great.
and
That's
then
right.
so that's why you have to
Yep,
alternate.
yep.
And then there's you that just pops ibuprofen
Oh, I do
just
not pop
whenever.
ibuprofen. I take a reasonable amount of ibuprofen.
The
My
recommended daily
don't
allowance.
yes,
Yeah,
Dr. T, my kidneys are fine.
crushes it up and puts it in his coffee in the morning.
As long as
What's
you're not eating blueberries, I'm okay
That's
with that.
I
right.
know. Oh
Yes,
my gosh.
horrible for your kidneys
If
are
I'm
those
still getting
blueberries.
flack about that one.
I know people were really upset. So if you don't
they
know,
weren't
we're
upset.
referencing a live show that we did at the Hollywood Improv, and Dr. T here was our one of our guests.
Yes.
And I think did you ask him what foods were bad for the
I
kidneys?
did. I said, "What give us something. What's something that's yeah, I guess it was food. I think that's
Yeah.
food. What food is there anything that we eat or consume that's bad for the kidneys?"
Yeah.
And without
And
without
not
even
a
thinking,
beat. Yeah.
he just blueberries.
And the room audibly
There was
gasps.
this
Yes.
huge gasp. Blueberry, don't pry my blueberries
And it's a
away from
room,
me.
again, it's a room full of medical professionals, like intelligent
Yes.
people that know the body, and
It was
everyone just like immediately believed it and was horrified.
so funny because it's just like, wow, this is what misinformation is like.
Yes,
It's
this
amazing.
is how it happens.
Of course, he told everybody. So yeah, what was the did you get any reaction from the people you work with?
No, it's like random people I don't even know. Like the other day, this surgeon that I barely interacted with yelled down the hallway. It's like, "Hey, blueberries!"
Yeah.
I'm like, "What?"
That's your
So
name now.
yeah, that's what they call me. But no, I had a lot of people tag me on social media and be like, "Is
Yeah.
this true?" And I was like, "No, it's not true." I was just thinking at the time when as you were asking me that question, I was thinking, what can I choose that would mortify a California audience the most? It was
Yeah.
either avocado or blueberries.
Yeah,
Those
I
are
was
the
about to
two.
say
Right.
avocado.
Avocado.
Avocado would
Yeah.
have been a good one.
It worked. Yeah, it was very successful.
Yes,
Yep.
absolutely.
But no, blueberries are good, everyone. Eat
Yeah,
your
no, they're
blueberries.
good. They're good.
And
They're
s- and
definitely
since
good.
and since then, you've launched your comedy career. Is that right? This-
Yeah, no, Big Blueberry has been after me. I have a date in
Mhm.
court with their lawyers.
Is their mascot just like the Kool-Aid guy, but blue?
Yeah.
Big?
no
No?
idea.
Nothing? Okay, sorry.
Um, we have another story gave us, and these are also some of our favorite types of stories, coming of age stories.
Mhm.
You know, the things we go through in medicine that make us grow up. I mean, we are grown. We're fully grown people, but grow up in the sense
As
of
doctors.
of yeah, of learning something, some valuable lesson. And so tell me about the time that you were alone in the ICU as during a blizzard.
So this happened in early 2000s, and this was in the town of Brockton, Massachusetts. And Brockton is famous for two things. One is producing championship boxers. A
Really?
lot of famous boxers came out of that small town.
Hmm.
Um, of course, now that I said that, I'm blanking on who. I want to say Rocky Marciano. I could be wrong, but there were a couple of like famous boxers who came out of Brockton. And then the other thing that is famous for is terrifying internal medicine residents because there's a community hospital there that's part of the rotation that we had to do, where for a couple of months we would do ICU there. And we would staff that ICU. It was a small community ICU, so it was like 6 beds or something like that,
How
10 beds.
close is this to Boston? Are we
It's
like
about
we're
40 minutes out.
okay? All right, gotcha.
And so you were there on call by yourself with an anesthesiologist who is a critical care covering person. And this was during a horrible blizzard. And the blizzard had shut down all traffic going to Boston. We were basically isolated. It was kind of like The Shining, but scarier. And there was a patient with pancreatitis. And pancreatitis is one of those conditions that there are two conditions that you can deal with in the ICU that go south like really fast. And one is pancreatitis, where if
Mm.
there's inflammation of the pancreas, if that starts to explode, someone can go from talking to you and feeling fine to being on death's doorstep in less than 24 hours. And the other one is a gastrointestinal bleed. If someone has a GI bleed, they can go from normal to just exsanguinating in minutes. So this was a young patient with pancreatitis. We all rounded. All my co-residents left before the snow really started coming down. So I was by myself. The anesthesiologist had these emergency surgeries, so he was out of commission. He was sort of talking to me on the phone when he could, and I'm watching this pancreatitis patient, it's a young guy, and the poor guy is just decompensating and decompensating. And it occurs to me about halfway through my shift, and this is nighttime now, that he's going to die. I have to get him out of this hospital. I don't have enough, support and all the ICU
Mhm.
stuff. He needs to go to a big center and it's a blizzard. And so what do I do? And I'm trying to call the anesthesiologist and like, sorry, he scrubbed in. There's another thing going. He said, just figure it out. Just
Oh
Just
God.
figure it out.
And
Oh
I'm
my
like,
God.
what do I do? So I'm calling. I
Uh,
start just looking in the phone book and calling hospitals in Boston. So I'm calling
oh my
Mass
God.
General Hospital. I'm like, can I speak to your ICU? And then the ICU attendings there are like, no, we don't have any beds. And finally, I get to this one hospital. I think it was Brigham, and they were like, "We have one bed, and we have 7 people waiting for that bed,
Oh,
but yours
jeez.
sounds the sickest." And then they grilled me on a bunch of formulas. They're like, "What's the Ranson's criteria? What are all these things?" And I was like, "I just happen to have them because I'd been freaking out this whole time." And they said, "Okay, fine, we'll accept them." And I'm like, "Yes!" And I hang up, and I'm like, "Wait a minute,
How do,
it's a
How does
like, how
it
do I
get
get him there?
there?
Like, what do I do?" So I call, and they're like, "Sorry, our ambulances can't make it." And I remember I looked up online this like helicopter. I was like medical helicopter search, and there was like this medevac thing and a 1-800 number.
Oh my
oh
So
my
gosh.
I called it
whoa.
up. I was like talking to my charge nurse. She's like, just call. What's the? I was like, do we have a heliport or thing? And she's like,
Yeah.
no. I was like, all right. Well, so I called him up and I'm like, look, we don't have a heliport, but I need to get this guy out of here. And the guy was so calm. I'll never forget. You know how these pilots always have these Chuck Yeager voices? They're super calm.
Oh
And
yeah.
he's like,
Like
we got
nothing
you up on the
phases them.
screen right now. And there is a baseball field at the school across from you guys. We'll land there. And I was like, oh my
Whoa.
God. And so they come and they land, and these guys show up. And in my eyes, I'm like crying. They're moving in slow motion. They've got the whole thing. The med flight nurses are super professional. They take him, he's intubated, he's on drips, and they're like, we'll take care of it. And then as they're rolling out, the last thing he says to me, he like grabs my shoulder and he says, Brigham, right? And I'm like, yeah, Brigham. And I'm like, in my mind, I'm like, or was it Boston
Oh,
University?
Oh no.
Or was it I was like, nope, they're gone now.
that's it.
But
Was
yeah,
it the right? Did you tell him the right place?
it was the right place. It was the right place. He got
Why do they
there.
all start with a B?
Yeah, I was like, yeah,
Wow.
yeah, Brigham, Beth Israel,
Yeah.
Boston. And so yeah, the guy survived. He made it out. But that was like my
Oh my
moment where I
God.
lost imposter syndrome after that. I was like, there's nothing that I
Yeah.
can't handle.
Right.
Yeah. Wow. Was this so this was how big was this ICU? Because I'm comparing it to the ICU that I had to work in my intern year because that it was a small community hospital and I had a similar experience where I was all alone at night.
Yeah. Yeah.
And
It was like I can't remember if it was 6 beds or 10 beds, but it
yeah.
it was like one little like U shape with all the beds there, and it was just absolutely terrifying just being on call.
Yes. I think
And they had
nighttime in the
this
ICU is one of the scariest places in
Yeah,
the
I don't think
hospital.
you had the same experience of it getting rid of your imposter syndrome. I think it just deepened it.
More like reinforced my desire to be an ophthalmologist is what it did.
Yeah.
I am not cut out for critical care medicine. That's not for me. And I remember did you have in this place, did they have the remote monitoring system?
uh, they did, but we couldn't. I mean, no, they didn't have it where we could monitor it remotely and not be in the room. We had to be around. They had a
Like,
central monitoring that was doing telemetry, but we weren't able to see that.
so you didn't have like the voice of God
Oh
thing?
no, no, we did. We had this little emergency pager system that was like World War II walkie-talkie kind of thing, where there would be a loud burst of static that would wake you up to evacuate your bowels and pee at the same time because it was so terrifying. And then you would have to like take it and talk into it.
I'm learning some things about our
N-
healthcare system
Now,
in this conversation. First of all, who cares how sick you are? We don't have beds. That's what determines whether you get care. And then our technology, our fax machines and World War II intercoms.
now might be a good time to remind to reassure the good people of Brockton, Massachusetts. You'll be fine. There's good people working there. You'll be all right.
Yeah, that hospital, it's a lot. You know, this was a blizzard in extreme circumstances, and the
Right.
patient did
Yeah.
fine. So everyone's
Exactly.
going to be fine. It's a
But
great hospital.
Kristen, you do bring up a good point. Like I feel like available beds are like a huge
Like, can't we just get some more
issue.
beds?
Well, I mean, you make beds. Like that's why you have people that board in the
Yeah.
emergency department for, 3 days
Do we need
sometimes
more
because they don't
hospitals?
I, I think
Are we going to solve healthcare today?
yeah, let's do it. How much time do you got, Dr. T? Can
All
we
right, let me cancel my schedule here. This is
No, I think there's a lot that goes into
Yeah.
available beds in hospitals and which patients get admitted and
This is one of those things, though, that as a patient, right? Like when you
Mhm.
don't know all the nuance behind this issue, it just looks like we'll get some more beds then. Like, come on, guys,
I will say
seems like a solvable problem.
that they thank goodness we have a thing called EMTALA, which requires that people who need medical care, like in an emergency setting, receive it. Like if you
Yeah.
come into the emergency department, you have to be seen. Now that also is probably is why we have so much burnout in emergency medicine
Right.
because a lot of things fall to them because you have certain hospitals, certain places that will refuse to see patients or that don't want to see certain types of patients that have a certain level of illness.
Hmm.
And so there's cherry picking that does happen out there. So fortunately we have this emergency
Yeah.
system in our country, but it shouldn't all fall on them.
Yeah.
So I don't know. As There's a lot. We're opening up a
That's a
whole
can of
thing
worms.
here, but anyway, I'm glad that you survived. You personally got through that experience, and it's probably made you a better doctor, Doctor T.
yeah. I think it was one of those you know you get forged in the crucible moments. Where you figure out
Yeah.
what you're made of,
Hmm.
kind of thing.
And
Um,
uh, do blizzards still scare you? Did you have any like residual like PTSD?
That's why he
you
lives in
know,
San Antonio
Yeah, is that why
now.
you live in San
Why do you
Antonio?
think I'm in San Antonio? No, the one PTSD thing I did have, it was pretty funny. The tone for the code pager, that beep,
Uh-huh.
and the tone for the shopper's alert at ShopRite are the exact same
Oh boy.
hertz frequency. And so I
Oh.
stopped going there because every time there was a deed, I would stop and just like stare up, like
Waiting
and
for
wait for
instruction.
like the voice of God to come down.
No, wait, because at the hospital I was at Resurrection, in our ICU, there was somebody monitoring the ICU. And so when I was there alone, they would come over the speaker system and be like, "What's Winter's formula?" I don't know. Like whatever. I don't know. I don't remember what they would say, but they were like I was standing there, they would like and you just kind of look around like, "What the hell is
And it's a
that?"
voice that exists just to pimp you?
No, it was in my mind, that's what was happening, but they were, like, there to just help out remotely, but
Yeah.
they could like talk to you though,
Yeah.
and it was like a real person. I don't know where
So
they
someone's just,
were.
like, working from home,
Yeah,
keeping
I
an
don't
eye
know.
on this ICU.
I don't know. I Most of my terrible experiences from the ICU is fortunately there weren't a lot of like, I let a patient die or something, but it
Mhm.
was a lot of just angry attendings grilling me about different things. What are a couple of your favorite pimping questions, Dr. T? What do you like to ask
Mm.
about?
What do I like to ask?
Yeah.
I really
That
don't, honestly, I'm not just saying this. I really don't like pimping style questions. I feel like I know there's some people who think the yield is really high when people are uncomfortable and that kind of thing, and certain amount of stress is good for learning. But I try to make things as low key as possible. So my questions are often pretty mild. I don't ask students to calculate free water depth. There, ask, what's the delta here, or what kind of acid, I
yeah.
do ask generally kind of more bigger picture questions like what do you think the fluid status is here, or like if you
Oh,
had a
yeah.
choice of what to do with this patient, what kind of pathway would you go down, or that kind of, or why do you think this
Yeah.
patient's kidneys are low, so kind of more broad general questions just to get them thinking and engaged,
I love
and
it.
then we can
Yeah.
drill down on details together. But
But
nephrology is hard enough,
it all comes back to free water deficit
it
though
all comes back to
eventually,
free
right?
water. It's coming up
It's
sooner or later. It's gonna get mentioned. But no, nephrology is hard enough that it's too easy to kill someone's spirit, you know.
Yeah.
So I want them to be happy and engaged and getting questions right, and not being like, oh god, I got to get a calculator out, kind of thing.
You have 30 seconds to convince a med student to choose nephrology as a career.
Go.
Don't do it. No, I'm kidding. 30 seconds. So things about nephrology, why you should you do it. It's intellectually challenging. It's stimulating. You get to practice a broad spectrum of medicine in a wide variety of settings. You get to deal with acute, critically ill patients. You get stable, chronic patients. You get to form relationships over years. There's transplant patients, and just a huge variety of pathology
Mm,
and clinical skills. And you'll never be bored.
dang, that's
You
good.
did it.
Oh, that was good.
Yeah.
And then last question I have for you: what's your favorite IV fluid?
Well, at the end of
What
a
do you
long,
really
stressful
just like?
day, I just like to
Mm.
sip on some lactated ringers. Just like pour out a pour out a glass of good old LR and just
Wait, you're an internal medicine physician. You don't use lactated ringers,
you know.
or is that a myth?
Oh, there's been a big push back towards LR just because we're tired of causing acidosis with normal saline. So we're just like, just use
Mm.
LR. It's
And
I
the
use a lot
surgeons
of
are
LR,
happy.
and
And the
the
surgeons
surgeons
are
are
happy.
happy. It's just everyone's holding hands.
Well, let's also before we go mention your book, These Vital Signs. Tell us a little bit about it. We have it right here. We'll show
Yeah.
it to you if you're watching on YouTube.
Lovely
These
cover.
Vital Signs, wonderful cover,
I chose that color
and the
just
book.
for your bookshelf because I feel like
Thank
it
you. I
would fit.
really
It
appreciate
says a
that.
doctor's notes on life and loss in tweets.
So
Yeah,
yeah,
tell
that
us about your approach to this book because it's a really creative, like, way to do a book.
so my I would say probably my second passion after medicine has always been writing. I love writing. I've written ever since I was young. I've always kept a journal. And on Twitter in particular, I guess that's what got me engaged with med Twitter was I wrote threads. And my favorite topic to write about is humanism in medicine. And you know connecting with patients and all those kind of things are wise in medicine, and different issues in medicine. And so over the years I wrote literally more than 100 stories on Twitter, and that's where my following kind of grew, and people would message all the time and be like, hey, do you have a place where these are all kind of compiled where I can just go and read? And I kept saying no to that question enough times that I was like, you know what, I really got to write this down
Yeah.
as a book. And that's where that book came from. And it's a bunch of Twitter threads. I think there's like 29 or something stories, and then there are a bunch of essays, personal essays, and their autobiographical stuff. And I had the manuscript for about 5 years. I got rejected by everybody, pretty much, literary agents, publishers, and then finally one day I was gonna just publish it myself. And one day I was looking through the likes on one of my stories, and I saw someone, and it and on their bio it said VP HarperCollins, and I was like,
Mm.
no way! And I like
Oh,
immediately
nice.
DM'd them. I said, I noticed you liked one of my threads. There's plenty more where that came from. Dot dot dot. And then she got in touch with me, and it was just
That's great.
it was a miracle.
Wow.
It was an intersection of luck and opportunity.
You know, all those
Yeah.
people that rejected you,
Mhm.
cardiologists.
I
They're all
know it. I
all of them.
knew it.
Yeah.
That's what in my mind I was like, cardiologist.
Absolutely. That's the only explanation. Well, check it out. It's wonderful to read your writing, and it's I've been following you and reading your stuff on social media for quite some time, and so definitely check it out. These vital signs, and thank you so much for joining us. It's always a pleasure. We had so much fun talking to you during our live show a few months back that we had to get you on and talk some more. So yeah, it's great. Always a pleasure.
Thanks so much for having me, and thank you guys for everything you do. I mean, you really do a massive amount for medicine, for people, for patients, for survivors, for the caregivers, everybody. It means a lot. I talk about humanism, you guys live it. So, yeah,
Ah,
it's a privilege to be here.
appreciate it.
Oh, thanks.
Take care, Dr. T.
Take care.
Hey, Kristen,
Yeah.
you know what I have?
What?
A box full of eyelid mites.
Oh, you shouldn't
Look at these
have.
little guys. Look at their cute little legs and
And the
their
ribbing.
yeah. Look at this. This just
Right? What is
I want you to
why
just be
are
able
you
to
doing this?
experience all of them. Look at that. We
Okay.
got so many. We got so many.
Mm-hmm.
You know what these guys will do?
What?
They cause a disease called Demodex blepharitis.
That doesn't sound
Yeah.
fun.
So if you've ever had red, itchy, irritated eyelids, it could be because of this. You know,
Mm.
like crusty, flaky buildup on your eyelashes.
Yeah, that sounds uncomfortable.
No, it's. I mean, look, but I mean, they are like really cute though. Look at the little beady eyes. Look
Mhm.
at the.
Yeah. Okay.
Well, don't get freaked out by this.
Why not? It sounds
You get
awful.
just get checked out.
Oh,
It's an
well, that
eyelid.
does make more sense.
You gotta get checked out for this. To find out more about Demodex blepharitis, you go to eyelidcheck.com. That's EYELID check.com to get more information about these little guys and Demodex blepharitis. Love talking to Dr. T.
Yes, he's always so funny and he's so quick-witted.
He's
and
he's got a quick wit.
very unassuming and calm.
Which
but
makes
then,
sense.
Bam.
He's
you know?
because he's smart. He's a nephrologist.
Yeah,
I mean,
it's true.
they gotta be quick. They gotta come up with those calculations real fast.
Mhm.
So anyway, always fun to talk with him. And should we do a fan story?
Yeah, it's been a while. Let's do one.
Okay, this comes from Dove. Dove says,
Dov.
Dove, D-O-V. That's all we got. Said, love your content. About 10 years ago, the professor at Sydney Eye Hospital and I created the rules of the House of Ophthalmology
Oh.
with a large dose of poetic license from Sam Shem's The Rules of the House of Gods. There's a little take on that. There's like 13 of them. I'll read a few of these. I'll read a few.
Okay.
All right. First one, patient satisfaction post-cataract surgery is inversely proportional to income.
This seems correct based on what I've seen.
Mm-hmm.
you come home with.
I do think that's pretty much correct. It's so interesting too. You know, being in the Northwest.
Yeah.
You know, I don't know what it is. Maybe it's regional though. It might be more regional. I mean,
I mean, how do you tease
I don't
all
know.
that
How do you
apart?
tease that out,
Yeah.
right? You're not going to do a study.
Well, you're not. That's for sure.
But yeah, I sometimes miss treating those Iowa farmers
Yeah.
who are just happy to leave surgery with eyeballs.
Right.
And they don't like if they can see their field, they can see their
I mean, they're
equipment.
just happy to leave. Period. They're
they're
getting
just
back to work.
Yeah, they just want exactly. They just want to go back to work. It's a little bit higher expectations out where we are now.
Mm-hmm.
Whether that's income based, I don't know. Probably there's something to it. Anyway, I like that one. All right, number 2. One-eyed patients always injure the only good eye.
Oh.
This is like objects just tend to find your eyes, period. Like it's like I mean, it makes sense because you're always looking at the things that you're doing, right? And so things like bungee cords,
Sure.
metal grinding, little flecks of metal, they'll
Yeah.
find your eye. I don't know.
Right.
It's like this, they always find your eyes. That's why we should always be wearing safety goggles everywhere we go at all times.
Yeah. Hey, where's our safety goggles?
We should be wearing them right now.
No, but do we have any?
Yeah, we have some.
Where?
They're in our. We moved all the stuff over to the new house. We got the
Oh.
things. Yeah.
I-
You've never
I-
seen them?
No. I think we need to do a family safety meeting
Oh, we
about
do. Absolutely.
eyewear.
All right. Number 3. When things go wrong, take a deep breath and reach for the viscoelastic. That's a very specific surgery, ophthalmology surgery thing. And it's absolutely true. So I'm not going to go into details on that one. Number 4, if you're not sure what to do, start steroids. That's something as an ophthalmologist,
Inflammation,
yes.
right?
If you're
Steroids?
a non-ophthalmologist, don't just indiscriminately start steroids.
Yeah, like inject yourself to get big. That's what people will think of when you say steroids.
I do sometimes will start steroids if I'm not sure what to do to try to get a patient feeling better. And then you can always stop them later.
But you didn't. So that's for inflammation.
Yeah.
So, like generally speaking, if you don't know what's happening, try
Yeah.
reducing inflammation.
As long as you know there's not like an infection going on, then yeah, start some steroids, try to reduce the inflammation. We'll do one more. If you have started steroids and still don't know what to do, double the steroid dose.
This is not.
I take a little
inspiring
bit of issue in that
confidence.
one. Oh, well, it's all tongue in cheek.
Yeah.
Oh, wait, one more. If you still don't know what to do, take a photo. We love our photos in ophthalmology. It's a
Yeah.
very visual specialty.
It is.
No pun intended.
Yeah, seriously. Also, the photos that I don't love the photos. I hate the photos as a patient.
I know you do. It's very bright.
Yeah. So,
Very
maybe consider not doing the photos if you don't have to.
Oh, this is a good one, actually. If you don't test for syphilis, you will not make the diagnosis of syphilis.
It's true.
That's actually true because
Sure.
it's not something you think about, but syphilis for the eye, it can look like all different types of things. Like it doesn't have a very specific thing. Like it can be a number of different manifestations.
How
of
many
the eye.
times have you diagnosed syphilis? Like
Like,
many, few,
No,
rare?
few, like twice
Yeah.
in like 7 years.
How many times have you tested for syphilis?
More than that.
Okay.
Many more than that. All right. Thank you for that, Dub. I'll save the rest of them for another time. Send us your stories or anything you want to send us. knocknockhi@human-content.com. I shouldn't say anything. Let's
Within reason.
Within reason.
Yeah.
There's lots of ways you can hit us up. You can email us, knocknockhi@human-content.com. Visit us on our social media platforms. Hang out with us and our Human Content Podcast family on Instagram and TikTok @Human Content Pods. Thanks to all the great listeners leaving feedback and reviews. If you subscribe and comment on your favorite podcasting app or on YouTube, we can give you a shout out. Like today @ExistentialGuy21 on YouTube said about our Dr. Rubin episode. We need the immunologist/allergist as a character now.
That would be a
Yes,
good
we
character.
do. Absolutely, we do. I did a first day of allergy. First day of allergy.
Yeah.
I got to
Should
do
do
it.
it.
I'm going to get on it. Full video episodes are up every week on our YouTube channel @Glaucomfleckens. We also have a Patreon. Lots of cool perks, bonus episodes, or react to shows and movies, hang out with other members of the community, the Knock Knock High, and our little subset or little enclave of Knock Knock High people, too. We do overlap. We interact with each other. We have get-togethers. We have cookouts. Whatever. We're active in it. Early ad-free episode access, interactive Q&A live stream events, and much more. Patreon.com/Glaucomflecken or go to Glaucomflecken.com. Speaking of Patreon community perks, we have a new member shout out.
Woo!
All right. Joyce C., Gary M., Amelia B., Crystal T., and Sardi. So I love the one names.
I've got questions
Sardi. What?
about Sardi.
Sardi?
Yeah.
Sardi. Yeah, I like it. Shout out to all the Jonathans, as always. Well, first, welcome all the new members. All right, we'll find jobs for you eventually. Shout out to all the Jonathans, as always. Patrick, Lucia C., Sharon S., Omar, Edward K., Stephen G., Jonathan F., Marion W., Mr. Granddaddy, Caitlin C., Brianna L., K.L., Keith G., JJH, Derek, and Mary H., Susanna F., Jenny J., Mohammed K., Aviga Parker, Ryan, Mohammed L., David H., Jack K., David H., Gabe, Gary M., Medical Meg, Bubbly Salt, and
Pink Macho.
Patreon roulette time. Random shout out to someone on the emergency medicine tier. Jennifer B. Thank you for being a patron. And thank you all for listening. We are your hosts, Will and Kristen Flater, also known as the Glaucomfleckens. Special thanks to our guest today, Dr. Syed Tabatabai. Our executive producers are Will Flater, Kristen Flater, and Courtney Rob Goldman and Shanti Brooke. Our editor and engineer is Jason Portizo. Our music is by Omer Bensvi. To learn about our Knock Knock Hi's program disclaimer, ethics policy, submission and verification and licensing terms, and our HIPAA release terms, all of them, go to our website, glaucomfleckens.com, or reach out to us at knockknockhigh@human-content.com with any questions, concerns, or recommendations to help me talk faster. Knock Knock High is a human content production.
Knock, knock. Goodbye.
Hey, Kristen.
Yeah.
Weren't you just talking about how much you hate admin work?
Yes, it's the worst.
Yeah, we don't like it much in medicine either.
Yeah, no one does.
Fortunately, we have DAX, though.
I know, you lucky ducks.
Yes, the Nuanced Dragon Ambient Experience, or DAX for short. This is AI-powered ambient technology that is incredible at reducing admin burden.
Yeah, it helps with your documentation, which is the worst part.
Yeah, it improves the physician-patient relationship. We can get back to what we love to do, which is just taking care of patients.
Yeah, kind of ironic. It's AI putting the human back into medicine.
That's exactly. And DAX is so great, you should ask for it from your company. In fact, 80% of patients say that their physician is more focused with the DAX Copilot. 85% of patients say their physician is more personable and conversational with DAX Copilot.
Do they make a home version?
To learn more about the Nuanced Dragon Ambient Experience, or DAX Copilot, visit nuance.com/discover-DAX. That's nuance.com/discover-DAX. Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts, or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.